It's probably a good transition point to talk about post-op care and what that's like. What are these? What are you telling these patients? What are expectations? Time to recovery, different things like that. Can you talk about that?
So just talking nasal valve surgery, not the whole rhinoplasty, rib and all that stuff, but like nasal reconstruction. But usually I'll use splints, internal splints, elastics. If I reorient the lower lateral cartilages, I'll also put these external splints on the outside on the nasal sidewalls. It helps prevent remigration or cephalic migration of those grafts. And usually I have them in there for about 7 to 10 days. It's kind of miserable, but you just don't want any scarring to kind of, contract and push down or migrate any of those grafts because that would be pretty detrimental. Usually I tell them they have the mustache dressing under their nose and they'll typically bleed. It's like clockwork. By 24 hours after the surgery, the oozing will stop and they don't need that mustache dressing. At that point, I have them start irrigating out their nose. So they'll irrigate out their nose about 4 or 5 times a day, even with the splints in. And I tell them it's not going to get in. It's just really to keep the crust in the clot, the growing bacteria, or pulling on a stitch or pulling on a graft.
Yeah, for your silastic splints and the external splints that you're placing as well, are you cutting or carving those out of silastic sheeting, and how are you securing them? Tape or sutures, or what does that look like?
So yeah, I use the thin silastic sheets. I don't use like the ones with the little tubes in them. Those are really thick and uncomfortable. Conceptually, patients are like, "Oh, I want that so I can breathe," but they never breathe and they're really thick and they kind of hurt the patient. So I put these silastic sheets on the inside and I secure that one with a 3O Proline. And then I'll cut the sheets into little rectangles and put them on the nasal sidewalls as well, and kind of like a bolster, and bolster down the sidewalls. And I'll use like a 3O nylon for that. I don't know why I do nylon for one and Proline for the other, but the color difference, I don't know, it makes me like identify different parts of the nose and be like, it's easier to take out. I don't know. It's maybe voodoo. Who knows?
So when you do the sheeting inside the nose, do you roll it or just put it in flat along the septum? Like, are you rolling it as a lumen in a tube or just putting it in
So
flat?
usually I put them on either side of the septum, and then I have like the top edge of it roll up to like sit in the internal valve area. So like I know a lot of people will trim the
Okay.
silastic so it's just sitting flush against the septum and doesn't roll up
Mhm.
in the internal valves.
So it gives it that support where you put the
Yeah,
squares
so
when it
and
rolls
then you
out.
just sit there
Okay.
and you have it sit there for a week and pray that, the grafts don't move. But yeah, it's worked great, and patients, they have a lot of great, the best part is when you take that stuff out and they can breathe great and they're like, "I haven't been able to breathe like this in years." And, there's tears and hugs
Yeah.
and, they're naming babies after you. But no, it's I like to have it roll up just a little bit to provide that support.
And that comes out after, you said, 7 to 10 days.
Yeah.
And then after that, just saline forever.
Exactly. No, you could probably tell I'm a little on the aggressive side, but I'll tell them if I tell a patient to irrigate 5 times a day, they'll irrigate 3. If I
Yeah.
tell a patient to irrigate 3 times a day,
Yeah.
they'll, like, never irrigate. So I tell them 4 to 5
Yeah.
times a day for the next 6 weeks until I see you at your second post-op, just so that, again, you don't want a crust pulling on the septum, causing a perforation or migrating the septum or causing exposure of a graft. So, yeah, I tell them about 5 times a day, just use the salt water rinse. We provide it, I give it to them for free, so, like, they don't, like, come back and say, I ran out of salt," or I just want them
Yeah.
to, we're all surgeons, we want our patients to have the best possible outcomes, so but usually I'm pretty aggressive with the irrigations and,